Hello, good evening. I'm your host, Dorothy. Welcome to tonight's IVF webinar with Professor Luciano Nardo from Reproductive Health Group, UK. Luciano, how are you today?
I'm very good, thank you. Thanks, Dorothy, for hosting the webinar. I'm very good, thank you.
Thank you so much. I hope everybody can hear us. Let us know in the chat section if you can hear us fine. Okay. I'm very happy you can join us, Professor Luciano, in this Stronger Together initiative for patients. I'm very proud to say that our online events are the winner of Medical Travel Awards 2020 in the category of Best Marketing Initiative. Our initiative wouldn't be possible without the amazing support of our ambassadors and partners, and you can see them here on this slide. Well, today we are talking about egg freezing and some case studies and patient stories. And Professor Luciano, are you ready to begin?
I am indeed, yes, thank you.
Yes, okay. Let's start.
Thank you. So thanks once again, Dorothy, for hosting this webinar, and thank you for bringing up the topic of egg freezing. First of all, I would like to congratulate you on winning your recent award. And second, I would like to thank IVF Media for providing such a good platform for members of the public where to improve their knowledge as well as to gain information about available treatment options to those trying to conceive, as well as we will hear tonight, women trying to preserve their fertility. The topic tonight, egg freezing, I think is well known to everyone. We have got a case study tonight, but we'll also be talking to you about different patient stories. The Ethics Committee of the American Society for Reproductive Medicine found elective freezing to be permissible, also to enhance fertility autonomy and to promote social equality. So it should not be, however, a form of reproductive insurance. And the reason being is that women should make an informed decision about freezing their eggs, not because they are planning to delay the motherhood, but simply because they believe that freezing their eggs at a time when it's possible will afford them a better chance to have a family, should that be needed at a later stage. We know that the best time to freeze human tissue, and we're talking about eggs tonight, is when individuals, women, are healthy, when they're young, when they have when they haven't got any underlying medical problems. So it goes without saying that egg freezing is very much an option for women that are looking to preserve their fertility, but at this point in time, they are generally healthy and well in themselves. We have learned, probably in the last decade, that there are many indications for egg freezing. Legal, some medical reasons, patients with cancer, but also social indications. The social indications are generally afforded to women that are healthy, young, that they make the decision to freeze their eggs because they haven't got, they're not in a relationship, or they're aware of some underlying family circumstances why they may be at risk of reduced ovarian reserve later on in life. We know also that in Europe, many women are embarking on egg freezing because of workplace factors or lack of partner, or indeed some demographic forces. However, the point of tonight's webinar is to educate our patient population that you should not be freezing your eggs because you are intending to delay your motherhood. And also, I will be talking later on about some case studies when the best time to freeze your eggs is when you're young, healthy, not when you are in your late 30s and perhaps thinking what to do, whether you should go ahead and freeze your eggs because you're not in a relationship. What we know, and I think this is very interesting data, that women undergoing egg freezing, they have learned about egg freezing from some webinars like the one we're running tonight, but mostly more than 50% of cases from a friend. So it is becoming itself a topic that is discussed in bars, restaurants, and on the web, social media, and many of the patients coming to our clinic, they have actually learned about egg freezing from somebody else. However, what is interesting is that nearly 80%, 85% of women embarking on egg freezing, they are at the time of undergoing the egg freezing program single. Now, I don't think that being single or being in a relationship should be the main reason why women pursue egg freezing. Instead, the decision to undergo an egg freezing program should come from an informed decision, an informed knowledge of one day perhaps seeing their ovarian function declining, and that day may well be the time when they use their eggs. The issue we have at the moment in the UK is with the time the eggs can be frozen. And at the moment, eggs are like sperm, hence it's not equality, but hopefully things will change, can be frozen for a period of 10 years. So the argument could be that younger is the woman freezing her eggs, and perhaps shorter will be the time if she doesn't use the eggs by a certain stage when she actually can potentially use those eggs. Because if you were to freeze your eggs at the age of 30, you could potentially use up to the age of 40 when you're more likely to see declining ovarian reserve. But if you freeze your eggs at the age of 20, you may be at the moment required to use by the age of 30, when it is still a good age to potentially conceive naturally. So this is an argument, but I sincerely hope that the law will change in the UK and the time to cryopreserve eggs will be extended and will be matching what we have at the moment for the sperm. However, let me just share with you some of the limitations and the risks of egg freezing. I think we talked already about chronological age. And I think before you embark on an egg freezing program, you should not just be told, oh, well, because of your age, you're not suitable or you're suitable, but irrespective of chronological age, you should have some ovarian reserve tests. And these are the AMH test and an ultrasound scan to assess the number of antral follicles. Once you have had the ovarian reserve test, then a fertility physician like me will have the information to advise you whether it is possible, what are the chances of success. However, please bear in mind that chronological age, as well as the blood test for AMH and the ultrasound scan for antral follicle count, will not be able to tell me what your eggs are like, whether they're good or not, whether they will survive if one day they have to be defrosted or not. So it is important that we accept that there are some limitations prior to embarking on egg freezing. It is important that we assess ovarian reserve so that you can have the information you need to make that decision. All patients coming to my clinic, they will have a blood test for AMH, will have an ultrasound scan, and will be informed of what the chances are of a successful outcome, such as the prospect of having eggs that can be cryopreserved. However, ultimately, the number of eggs to be cryopreserved and the quality of those eggs is only established at the time of egg collection. Amongst the risks of egg freezing, we have ovarian hyperstimulation syndrome, which is when the ovaries produce too many eggs. But indeed, there is also some risks with the surgical procedure to harvest the eggs, although it's very simple. But there are risks of bleeding, infection. The procedure is done under sedation, so you will be asleep. And that itself poses some risks, although very, very slim. But one thing that I always bear in mind when women come into our clinic, wish to freeze their eggs, is what is their emotional status? And if it's true, and it is true that 80%, 85% of women freezing their eggs are single, then that opens another argument. Do they have enough support at home? Are they anxious? What emotional support do they need from the clinic? And that aspect is very important to me and my colleagues at the Reproductive Health Group. We offer patients embarking on the egg freezing program counseling if they need to, because we appreciate that some of them may not have a large family or may not want to discuss with friends or with family and may be single. So it is important that they feel very supported. So if you're embarking on fertility treatment with a view to freezing your eggs, please do ask for some emotional support, some counseling, if you feel that could be of benefit to you, if you haven't got anyone to talk to, if you're single. But do not just embark without having all the information you need in order to make yourself feel at ease once you start the process. The last thing I like to say before passing the platform back to Dorothy is that we have made a significant step forward in the field with regard to egg freezing procedures. We now use a technology called vitrification, and that allows good eggs to be cryopreserved quickly, and to be cryopreserved with very little risk to the eggs. Just to give you some numbers, we know that obviously it's very much age dependent, but in women of chronological age under 35, up to 80% of the eggs can be mature, can be frozen. And again, about 75 to 80% of these eggs will survive the thawing process when they are defrosted. And the fertilization rate of the eggs that survive the thawing process is very, very similar, is comparable to fresh eggs. So please do not be afraid of freezing your eggs if one day you need to use them, because you have concerns about the quality of those eggs. But instead, what will affect the quality of those eggs and the chance of success will be probably a low ovarian reserve in women of advanced chronological age. And that will be probably women of the age of 35. This doesn't mean that if you are older than 35, you should not freeze your eggs, but simply that you have to set your expectations so that you will not be disappointed. And also, let me just say to you that there is evidence to suggest and to confirm that women that embark on egg freezing, we will have the same chances of achieving a live birth if they're using fresh eggs. And we have got a number of studies published in the literature looking at the use of vitrified, so frozen eggs with fresh eggs, providing the same live birth rate. And also comparing the vitrification, which is the freezing of eggs and the freezing of embryos. Some recent studies suggested that the technique is so good that will not affect the eggs, although they are much weaker and to some extent frail cells as compared to embryos. So I sincerely hope that this brief introduction to the topic has set the pace for what's going to be an exciting evening with a case study and then some patient stories that I will share with you tonight. Dorothy, back to you. Thank you.
Professor Luciano, thank you very much for your talk. And tonight we have a special guest with us, Ella. Ella has been a patient of Reproductive Health Group in the UK. Hi, Ella.
Hi.
How are you?
Good, thank you.
Perfect. We have several questions prepared to Ella, and she will answer them. She will try to share with you her experiences after her egg freezing treatment at the clinic. I hope you will enjoy this patient case study. After that, a standard Q&A session will follow, where you will be able to ask questions to Professor Luciano. So you can start typing the questions to the doctor in the chat section. Okay, Ella, I've got the first question prepared for you.
Okay.
Let's start. What made you decide to freeze your eggs?
So my mom actually struggled to have children herself. And so when my older sister found out that she had a low egg count as well, and that she might also struggle to get pregnant, it was her doctor that thought it might be likely that the problem was genetic. So that led me to get in contact with Dr. Nardo, and I had an AMH test there where I found out that my egg reserve was also low. So I'm only 23, so I'm quite young really to kind of be going through this. So it was quite a shock and also quite difficult to process it all, as it happened all quite quickly for me. So yeah, after discussing it with Dr. Nardo, we decided that my best option would be to freeze my eggs now so that I'd have more options in the future when I was kind of ready to start thinking about starting a family then, because obviously at 23 I'm not really ready to do that yet.
Thank you. We've got another question. What things did you consider before making the decision to go ahead with egg freezing?
Well, it all happened quite quickly for me, so I didn't have a lot of time to really think about the process or what it would really involve, because I think it was about a week after having my AMH test and getting my results that I started the injections for my first round of egg freezing. Obviously there's lots of things to consider. It's a big thing to do with the injections, with surgeries and everything like that. But I think it was obviously like money, and the cost of the treatment was a huge factor to consider as well. As I said, I'm quite young, and this was something I never really planned or took into account financially that I'd have to do at this age. But luckily for my family were able to help and support me with that, which enabled me to kind of go ahead with that. But like Luciano said before, the 10 years of freezing was something I had to consider. Obviously at 23, that would potentially mean that I'd only be able to freeze my eggs until I was 33, which is still so young. But obviously with such a low AMH level, that was kind of just something I had to do at this age, regardless of the 10 years.
Thank you, Ella. Another question we have. Did you have any counseling before the process started? If so, did you find it useful?
So I didn't have time to have any counselling beforehand. However, I did have a few sessions during and then also after my first round of egg freezing. And I found it really helpful and just nice to talk to someone that was completely external to the situation, who didn't know me, and that I could just be kind of open with. I've got a really lovely group of friends that are really supportive, or as supportive as they can be, but obviously you are the only person that really knows what you're going through, and they try to be there, but they don't know what it's like. And like I said, my family are really supportive and were able to finance it for me. But I think in some ways that made me feel kind of guilty if I would complain about it. Obviously, it's quite a tough thing to go through. You feel tired, you can feel sick, you can feel just fed up in general. So having a counsellor to talk to and just tell them how I felt and be able to talk through things was I found really, really useful.
Thank you so much. Another question. How did you decide which clinic to use for your egg freezing?
So I mentioned earlier that my sister was going through it just before I did. So it was actually her, she lives in London, so it was actually her IVF doctor that recommended Luciano and his clinic. So that's kind of how we first got in touch. And I remember being really nervous for my first appointment. I didn't know anything about IVF or egg freezing. I had no idea what to expect. But they just took the time to explain everything to me, from going through all the consent forms, how to do the different injections, like all of my options, how I might feel, and the counselling that was available. And I just remember after that first consultation appointment, feeling so relaxed and at ease that I could just ask any questions whenever I needed to. And I felt completely reassured that the clinic would just be there to support me throughout the whole process, really.
Thank you so much. And the last question, how did you find the process overall? How do you rate your experience?
Obviously, it's extremely nerve-wracking, especially at the start, kind of going into it, not knowing what was involved. And I think it can feel a little bit like information overload at the start, which was quite difficult for me because I was still trying to process and accept that I was even having to do this. I think that that's the same for any woman. You kind of take for granted that you can just have children. And so to be told that you might not be able to, or that it's not going to be as straightforward as you thought, can be quite difficult to accept, especially at such a young age when it wasn't even something that was really on my mind yet. However, once it all was kind of started, it all just became a little bit easier. The appointments and the injections kind of became normal and part of my daily routine in a way. And as I said before, my sister was going through it at a similar time, which was helpful because she was kind of able to tell me what to expect at different points. However, she's married and they were freezing embryos instead, which is obviously different. And it also meant that she wasn't really going through it alone. She had her husband there. So whilst I had a lot of support from family and friends and also from the clinic, like Luciano said, with like counselling, I was going through it alone in that sense. So yeah, the counsellor definitely helped with that point as well, I think. But yeah, I think overall I remember just feeling quite tired and sometimes fed up and stuff. But I remember also being worried about the success of it and how many eggs would we get and was I doing the injections right and stuff like that. But I think you do get used to it all quite quickly. And I also knew that I had the nurses and Luciano there at that kind of the end of the phone. Whenever I needed to ask a question, I could text them or call them. So that really helped to reassure me that I wasn't doing it alone either.
Thank you so much, Ella. It's wonderful that you could join us tonight and, and share your experiences. I do hope that other potential future patients get inspired by your story and they can relate to it. Thank you so much. Due to some time restrictions, Ella can only answer those 5 questions. But now back to Professor Luciano and the Q&A session. Shall we start?
Yeah, thank you, Dorothy. Before actually starting the Q&A session, let me just share with our audience a couple more case studies. I remember about 12 months ago seeing another lady come into our clinic with also reduced ovarian reserve. And she was very anxious from the very beginning about embarking on this process, and she'd not discussed it with anybody. She'd not discussed with anyone because she felt that actually was, to some extent, embarrassing having to discuss the topic of freezing her eggs because at her age she had reduced ovarian reserve. So we helped her in understanding why she had to discuss, understanding what would be the benefit of discussing with other people. And eventually she actually came back and said, she and her family had appreciated the benefit of freezing her eggs, and she had the full support of the family, which helped her incredibly going through the process. This lady embarked on 2 consecutive cycles of IVF egg freezing. She was traveling to our clinic from London, and we managed to freeze a good cohort of eggs on both occasions. And she was indeed very grateful for freezing the eggs. But she was also surprised because the number of eggs we did manage to freeze on the 2 occasions she embarked on treatment was completely different than what we expected to be based on our ovarian reserve tests. So the reason why I'm sharing this case study is because we cannot always rely on indirect information coming from tests such as the AMH and antral follicle count to determine how many eggs we are going to collect. This specific patient had very, very low AMH levels. She was under the age of 35, and I was the one saying probably we will get no more than 4 to 5 eggs. And we ended up collecting the first cycle 10 eggs, and we did the same in the second cycle. So the difference between a woman and a man is the man can produce a semen sample, and quite objectively you have an assessment of his sperm parameters. But sometimes for women it's different because we rely on information coming from tests, and what we see at the time of a collection is different. Another case study I would like to discuss tonight is of a lady that actually wanted to freeze her eggs, and she was at the time, she's now older than 35, and she decided to freeze her eggs because she had just ended a relationship with her partner. She wasn't quite sure about when to enter another relationship, and she was quite upset about the prospect of one day potentially not having her own child. So she wanted to freeze her eggs so she had time to settle down in a new lifestyle and routine without having to panic about the future of the prospect of being a mother, nor finding a partner with whom having a family. So she was counseled by us. She received counseling by the independent counselor. She received all the facts and the figures she needed to have before embarking on the treatment protocol. And we ended up freezing again a good cohort of all sides. And she then came back and said actually she wanted to use those eggs with donor sperm. So she had made her own decision without feeling the pressure at the time to embark on donor sperm IVF treatment. And this is very important. And whilst I do not agree that egg freezing should be seen as an insurance policy, because in that case could encourage women to delay motherhood, I don't agree that egg freezing should be offered as an employment benefit, because again, women may feel that they have been asked to delay motherhood. However, egg freezing should be considered an option for women like Ella, that are young, fit, healthy. However, there are family history of early menopause or early declining of ovarian reserve. Should also be used by women that are fit and healthy, and they're not at that point in time in a position to start a family for whatever reason, and they want to preserve the eggs just in case they are needed one day. And also from women like the one I've just discussed that may come out of a relationship and they be they're at that point in life when they don't want to be under pressure about starting a new relationship because they want to have a family. And they may consider freezing their eggs or their eggs just to give themselves a little bit of space and time to come together, to recover from any emotional damage that a relationship breakdown can cause. But at the same time, have the time to rely on something they can use one day, should they not be fortunate or willing to enter another relationship. Thank you.
Thank you so much. And let's go ahead with the Q&A session. Okay, the first question is, what's the percentage of successful survival of eggs defrosted? I am 41-year-old, just starting embryo banking, as we have had 3 failed fresh eggs attempts so far.
Obviously, embryo banking is different than egg freezing. We know that embryos are much stronger cells than eggs. Within our clinic, the survival rate of blastocyst is 98%. The survival rate of eggs is about 80%. So embryos are much stronger cells. They survive better than eggs. But realistically, and based on data in the literature, the chances of success of having a healthy pregnancy using frozen eggs and fresh eggs is very much comparable. One of the best published studies coming from a Spanish group shows that the clinical pregnancy rate per embryo transfer using frozen eggs is around 55%, and the clinical pregnancy rate per embryo transfer using fresh eggs is again 55%. So that is very encouraging.
Thank you. Another question.
Actually, Dorothy,
yes.
Sorry, before I move away from this, because I think it's very important given that we've been told the chronological age of the attendee. I think the clinical pregnancy rate obviously changes with chronological age. And I think what we know that women that are chronologically older will have a significantly lower chance of success than women that are younger. And for women of the age we just had, I think the chance of success using frozen eggs probably will be 10% or below.
Thank you very much for adding this. Okay, let's go to the next question. Would it be possible to send that link of the study that compared fresh versus frozen success rates?
I cannot send it now, but I can, if the person wants to contact me by email, I will certainly be happy to do so, or can contact my clinic by email. Is info@reproductivehealthgroup.co.uk, And I will make sure that you'll get the link to the publication.
Thank you very much. Also, I pasted the link to Luciano Nardo's page on our site. You can use this link to contact him, or you can use the email. Okay.
Yeah, it may be better if using the link to on your page, so actually I can reply directly, Dorothy.
Oh, sure. Yes, of course. Okay. Next question: are there any side effects from the injections?
There are no specific side effects from the injections. The injections to induce controlled ovarian stimulation for egg freezing. There are actually injections that have the same hormones that women produce monthly, regularly. The difference is that the hormones that are produced physiologically, they fluctuate, hence why women have unifollicular ovulation, which means only one follicle releases the egg. When women embark on egg donation, egg freezing, what we see is that they will be producing and they will be developing a much larger cohort of eggs. And the reason why they produce a larger cohort of eggs is because with the injections we normally give, they allow to support the cohort of follicles that were in the ovaries from the very beginning of the cycle. As such, one of the possible side effects of the injections is ovarian hyperstimulation syndrome, which is something I mentioned at the very beginning of this webinar. And the ovarian hyperstimulation syndrome is when the ovaries produce a very large number of follicles, and women can start having some fluid in the abdomen. They can, in some cases, have a swelling of their legs. They can have fluid in their lungs. Admittedly, the risk of ovarian hyperstimulation syndrome are very, very slim this day and age, with close monitoring and tailored stimulation protocols. Probably affect 2 to 3% of women embarking on ovarian stimulation. But that is, in our experience, the major side effect of the injections. There are no side effects such as changes in mood, changes in well-being, because the hormones are essentially the same that women produce on a monthly basis.
Thank you very much. Another question: since when does the possibility of freezing own eggs exist in the UK and in general?
Well, a very, very long time. I think in the UK, eggs have been frozen for probably 2 decades. I think the reason why egg freezing has not been advocated as much as it's been now is because the technology to freeze eggs wasn't as good as today. Vitrification, which is the fast freezing, has helped the cryopreservation of eggs, and more importantly, the preservation of eggs, which means keeping eggs intact after thawing. And just to answer more directly this question, the first human birth from cryopreserved oocyte was reported in 1986. So that is a very long time ago. If you think that the child that was born in 1986 and now is 34 was actually created in a laboratory using frozen eggs. So it is not a research procedure. It's not a research treatment. It's well established. And over the last 25 years, scientists have optimized the methods to cryopreserve oocytes. And I think today, scientists and clinicians would agree that vitrification is the technique to freeze the eggs and to allow these eggs to be preserved well for a very long time.
Thank you very much. Another question. I've just had a retrieval and could not do a fresh transfer due to some external factors, so I froze them. I got my period 5 days after the retrieval and feel it is too soon to do a frozen transfer with this cycle. Perhaps my cycle needs to have a full regular cycle first. I've had 3 IVF transfer failures.
Sorry, Dorothy. What is the question? Is about when to do the transfer?
I think the question is, do I need to do a full regular cycle first? That's what the patient is asking, I believe.
Well, yes, you do need to have a natural menstrual cycle before embarking on a frozen embryo transfer cycle. Now, of course, I think what we are talking now is the use of cryopreserved embryos, I suspect blastocysts, rather than the use of frozen eggs. But in a nutshell, yes, before you embark on a frozen embryo transfer cycle, irrespective of the reason why the embryos had been frozen, the recommendation is to have a natural period. If you don't have a natural period, then I would obviously in our clinic we would recommend to induce a period before you start a frozen embryo transfer cycle.
Thank you so much. Yes, the patient has confirmed that that was the question, so thank you very much for the answer. We've got another one. Okay, I understand that not all follicles contain eggs. However, what percentage of eggs are expected from mature follicles?
Well, all follicles have got eggs. The issue is some follicles may not have mature eggs. And hence why sometimes eggs are not collected at the time of a collection, because eggs within the follicles may not be mature and fully detached from the cells where actually the eggs are attached to. In our experience and in my over 20 years experience in the field, I see that probably 80 to 90% of mature follicles will have an egg. So within our clinic, we probably collect between 80 and 90% of eggs at the time of each egg collection. But we like the follicles generally to become mature before we trigger the final stage of the treatment.
Thank you so much. Another question. Let me find it, just 1 second. Is age a factor in the percentage of eggs achievable from mature follicles?
Is age a factor? Again, sorry, tell me.
Yes, please. Is age a factor in the percentage of eggs achievable?
Yeah, of course. Age is a main contributing factor, as we discussed until now. Age is a main contributing factor to the number of eggs we collect, to the quality of the eggs, and to the chances of those eggs to be fertilized successfully in vitro when they're defrosted.
Thank you very much. Another question, are their success rates different if you use a natural cycle rather than an induced cycle for the frozen embryo transfer?
Again, we're talking about using embryos, and the answer is no. We did a publication a number of years ago, and we continuously review the practice at the Reproductive Health Group, and we don't see a difference between fresh and frozen. I think what has to be said that one approach may work better for some women than another one, and all comes down to the time for transfer. I believe that the time when we do the embryo transfer is very, very important. Not all women have an endometrium that is receptive after a set number of days of progesterone. And the reason why sometimes the natural cycle may work better than an hormonally controlled cycle is simply because they have the opportunity to reach that phase of the endometrial cycle when the endometrium is probably most adequate for successful embryo implantation. But this day and age, in the clinic, most clinics like ours will have the ability to investigate the endometrium, investigate the endometrial phase, and detect when is the best time to do an embryo transfer. So if you have experienced previous failed embryo transfer cycles, either with hormone treatment or natural, I think the next step will be to have a endometrial biopsy when the endometrium can be studied and that we can identify when is the best time to do the embryo transfer, because ultimately the endometrium has to be receptive for an embryo to implant.
Thank you so much. We've got a few questions left. If you want to ask any more questions, please type them in the chat section. Here's another one. When you say older women will have a lesser chance, is that even if their eggs were frozen when they are 37 years old?
I think when we refer to chronological age, is the chronological age at the time the eggs were collected and frozen, not at the time the eggs were defrosted and fertilized. So if you have made the decision to freeze your eggs at the age of 32 and you use your eggs when you are 39, your chances of achieving a successful pregnancy outcome, they're not based on you are being 39, but when you're 32. I know in this case, I think you say that you may have been 37 when you did freeze your eggs. 37 is older than what I would recommend to be a good age for freezing eggs, but still you may have frozen a good number of eggs, a good cohort of eggs of good quality, and use them when you are 39 or 40. So your chances of success will be based at the age when you did freeze your eggs, not at the age when you're going to use the eggs.
Thank you so much. Another question. Don't PGD tested and good grade embryos have a higher success rate of a live birth than non-tested?
Absolutely, yeah. It is well established, and is our practice to perform pre-implantation genetic testing of embryos, especially in women that are chronologically older than 37, because of the increased risk of having embryos that can be aneuploid, which means genetically abnormal. Just to give you some figures, because I like to share numbers with my patient population. If you are under 35, the chances, or perhaps see as a risk, of having an embryo as a blastocyst that is genetically abnormal is probably 30%. If you are over the age of 39, the risk of having embryos that are genetically abnormal is about 80%. So creating embryos and genetically testing the embryos and selecting embryos that are genetically competent, i.e. normal, increases the chances of successful pregnancy outcome, but also reduces the risk of miscarriage. It is not a coincidence that older women have increased risk of miscarriage, because as I just said, they are more likely to have genetically abnormal embryos. So pre-implantation genetic testing, which means taking a biopsy of the blastocyst and sending the cells to a genetic lab for the tissue to be examined, and then we get the results and say, well, out of these embryos or blastocysts, this one is good. If you transfer that embryo, you've got better chance of success in terms of a healthy live pregnancy.
Thank you very much. We have 2 or 3 questions left. Other than thickness and 3-layer, is there any other factor to detect how receptive the endometrium is for the embryo transfer?
Yeah, absolutely. I think endometrial thickness and intralaminar appearance are just ultrasound features. They're not going to tell me if the endometrium is in the right phase of the cycle, is receptive or not. We like to use, for our patient population that have had repeated failed embryo transfer cycles, we like to test the endometrium by taking a biopsy after a certain number of days of progesterone to assess whether the endometrium is in the receptive phase or not. This can be done by assessing the expression of some genes in the endometrium. And based on the gene expression, the lab is able to tell us whether the endometrium is pre-receptive, is receptive, or is post-receptive. So it is very important to think that actually it's not just the thickness of the uterus, of the endometrium. It's not just the appearance of the uterus. It's not just the appearance of the endometrium that will determine how successful an embryo transfer is going to be, how good the endometrium is. But it's also whether per se the endometrium is receptive or not.
Thank you so much. Another question. So the clinic should do the study for the embryo if both induced and fresh cycles were unsuccessful. Is that correct?
I assume that we'll talk about genetic testing of the embryos. If you have had repeated embryo transfer cycles, I think 2 things are to be done. One is obviously in subsequent cycles to test the embryos. 2 is to check that endometrium is well prepared for implantation. So it's not just the embryo, it's also the endometrium.
Okay, thank you so much. We've got one more question. What is the name of the test for endometrium receptivity?
The one we use is called ERA, Endometrial Receptivity Analysis, or Endometrial Receptivity Assay. And we do that within our clinic as part of a combined test called endometrial test. So we'll not just be looking at the expression of genes during the implantation window or receptivity window. We'll also be excluding the presence of an abnormal microbiome. So we'll be looking at the expression of lactobacillus and excluding the presence of abnormal bacteria.
Thank you so much. So far, there are no more questions. I may have a question myself, if you could answer. I was wondering, how long is the entire process of egg freezing at your clinic? How long does it take for a patient?
From the time you've made a decision to when you can start the treatment, that very much depends on what stage in your menstrual cycle you've made the decision. So if you make a decision when you're mid-cycle, you'll probably be waiting 2 weeks in order to start the hormone treatment. From when you start the treatment itself, so from when you start the injections to when you have your eggs collected, it's probably less than 2 weeks. We say probably between 12 and 15 days at the most. Most women that come to our clinic to have their eggs frozen, they don't have to wait to start the process. So after the first appointment, we organize the blood test, we organize the medications that are delivered to the home address, and then we organize the virtual online appointment to sign the consent forms. And this is all done within a day or so. And then they are given the protocol and they receive the medications teach session by one of our fertility nurses done online. And they will be starting the injections on the first day of the period.
I see. Thank you very much. Okay, we have 2 more questions from the audience. Can the receptivity test be done as part of a fresh transfer?
No. No, the endometrial receptivity test is done as part of a medicated cycle. So we prepare the endometrium with some estrogen, and then we add the progesterone. And after 120 hours, or after 5 days of progesterone, we do a biopsy, and we wait for the results of the biopsy to tell me if the endometrium is receptive or not.
Thank you very much. Another question. How expensive is it to keep eggs frozen in your clinic each year?
Actually, it's not. It's relatively cheap. The cost of storage is £300 per annum. So, unlike other clinics, we don't charge a fee for 10 years because we don't believe that women know at the time they freeze their eggs whether they're going to keep them for up to 10 years. So we like to charge an annual fee, and that is £300 a year.
Thank you so much. Yeah, 2 more questions, probably more coming. Okay, this is maybe a question not about egg freezing, but generally about treatment. But let's have a look. I have only 4 embryos left, and I'm about to go through my second frozen embryo transfer. Would you recommend I get the PGD testing done and receptivity test if this next transfer is unsuccessful? I'm worried that I will be left with none, and I'm too old to use my own eggs now.
I think if you have concerns about what has happened before, you shouldn't wait until you have a failed cycle. I think you should consider to have your test done first, your endometrial receptivity test done as soon as possible, and then you make a decision whether it's worthwhile also having the pre-implantation genetic testing of the frozen embryos.
Thank you so much. Another one. Is there a minimum amount of time embryos need to be frozen?
No. Mm-hmm. We have frozen eggs, eggs and embryos as well. Embryos just for a few weeks, because we couldn't do a fresh embryo transfer. So no, embryos and eggs can be frozen for, for 1 day, for 1 month. Obviously, eggs at the moment for 10 years. Embryos can be frozen for 10 years too. No, there's no concern.
Okay, so patients can pay per month, per year, and so on.
There is no monthly payment. There is an annual payment, and that is £300 within our clinic. It will be difficult to charge per week or per month. So hence why we just charge for calendar year. So the time they're frozen, they pay the £300 storage fee, and they don't pay anything until 12 months later.
Thank you very much. Very useful. What is the chance that the embryos do not survive the PGD tests?
It's no matter of surviving the PGT test. The test is done after the cells are taken. So, and it's done in the laboratory. I think what perhaps the question is, what are the chances that embryos, blastocysts, will not survive the biopsy? I think I always say to my patients that the risk of the embryos being damaged by the biopsy are significantly lower than the embryos per se being abnormal. I think in our lab, the chances of blastocysts being damaged by the biopsy and the embryos not being able to be used in subsequent cycles is below 5%.
Thank you so much. Let's wait for one more question. Someone is typing. Okay, that was just a thank you from the patient, potential patient. Okay. Let's check if there are any more questions. And if not, we can finish.
Thank you, Dorothy.
Yes, I think there are no more questions. Professor Luciano, thank you so much for your talk. There are some thank yous from the patients. Yes, thank you from Angela. Okay, thank you so much. Ella, thank you so much for joining us tonight. I know you are there somewhere with us. You are listening.
Yeah, I'm here.
And Ella is here. Yes. Thank you so much for the presentation, for explaining everything. Would you like to add anything? Maybe some final words to women who are considering freezing their eggs but are hesitating or are not sure about the process?
I think if you are thinking to freeze your eggs and you're not sure about the process, what I would say is take the time to talk to others, take the time to read about the process itself, approach the clinic where you like to have your egg freezing done, perhaps have a visit, just see what the clinic is like, try to meet with the physicians and the nurses, have a feel of what kind of support you will be getting. But more importantly, try to get some information from the clinic about their experience with egg freezing, their experience with the egg thawing, so with the defrosting of the eggs, the fertilization rate. The process itself can be made very, very easy by the support you receive from the clinic, and also by yourself, the understanding of what you're going through. If you are thinking to freeze eggs, don't just be, don't rush into that decision. And I would highly recommend that you have the test we discussed before, AMH and antral follicle count, to add information to the decision-making process. Chronological age is an important parameter, is an important determining factor, but it's not the only one. As we've learned tonight from our live case study, Ella, she's very young, but she had very, very low ovarian reserve. And she would have never known she had a low ovarian reserve if she hadn't done the test to check what her ovarian reserve was. And indeed, the tests she had done were adequate at the time she approached the clinic because of her family history. So my recommendation is, if you're deciding to freeze eggs, get as much information as possible, contact the clinic, be confident that clinic is the right clinic for you, have the tests, and then seek some emotional support if you wish so before starting the process. But the process itself is relatively straightforward.
Thank you so much for these final words. If you wish to contact Professor Nardo at Reproductive Health Group UK, you can email him directly or you can contact the coordinators via our page. Thank you so much. It was a very educational, I think, event, and have a good night.
Thank you very much indeed, Dorothy. Thank you.
Yes, bye-bye. Thank you.
Bye. Bye.